Okay, let's pull up the sources you've shared and prepare for a deep dive that's all about mastering the details, just like the pros.
Sounds good.
Today, we're tackling two seemingly different, but actually profoundly interconnected areas from this medical text. First, the intricate world of oral health, how it's really a window into the body.
Absolutely.
And second, the intensely subjective experience of breathlessness, dyspnea. We're focusing specifically on the deep insights in Chapter 36 and the very beginning of Chapter 37.
That's right. And for anyone needing a really solid grasp of patient evaluation, recognizing the signs and symptoms in the mouth, it's fundamental.
It really is.
It's often the first place systemic diseases show themselves, or the source of local problems that can have much wider implications. And the text really emphasizes this close collaboration with dental professionals is just vital.
And then switching gears to dyspnea.
Yes, it's a cardinal symptom. One of the most frequent complaints we encounter, actually. So grasping its subjective nature and the complex mechanisms behind it is absolutely essential for effective clinical practice.
Exactly. Our mission today is to go deep into the source material, extract every important nugget, understand not just the what, but the why presented here. We want to give you that elite level grasp.
Let's do it.
So let's start with the structures themselves, the teeth and their supporting foundation, the periodontium.
Okay, so the text kicks off by giving us a timeline for tooth development, which is quite extended, actually. Longer than you might think.
How long are we talking?
It starts remarkably early. 6th week of embryonic life.
6th week. Wow, that is early.
Indeed. And it continues, the whole development process right through about 17 years of age.
17 years.
Yeah. So first we get the deciduous teeth, the 20 baby teeth. They typically finish erupting by age 3 and are usually all shed by around age 13.
And then the permanent set comes in.
Following those, yes. The 32 permanent teeth. They start erupting around age 6, mostly men by 14, although, as many of us know from experience, those third molars, the wisdom teeth, they can come in significantly later, or sometimes not at all.
Right. 17 years. Quite the biological project just for our teeth. So once they've erupted, what are the key structural components we really need to nail down from the source?
Well, okay, there's the visible part above the gum line, the crown. That's covered in the incredibly hard enamel.
Hardest substance in the body, right?
Pretty much. Below the gum line is the root, which is covered in cementum. But it's inside the tooth where things get really interesting clinically.
Like the dentin, you mentioned that earlier.
Yes, the dentin. It forms the bulk of the tooth structure, sitting underneath the enamel and the cementum. The source notes it's denser than bone, which gives it strength, but it has another characteristic, maybe even more clinically significant.
Which is?
The source uses this phrase, exquisitely sensitive to pain.
Ah, okay. Why is highlighting the dentin's pain sensitivity so crucial for understanding what follows?
That's absolutely key, because the dentin contains these tiny tubules with nerve fibers. Now, decay it often starts in the enamel, which is hard, mineralized, no nerve endings. So it's initially painless.
Stealthy.
Very.
Yeah.
But once that decay breaches the enamel and reaches the dentin, that's when that exquisite sensitivity kicks in. It becomes the patient's primary alert system. Pain signals the problem has progressed beyond just the surface.
The body's built-in alarm finally goes off, and right at the core, protected by the dentin.
That's the pulp. The pulp is vital, literally. It's the living tissue at the center, housed within the dentin. It contains the blood vessels, the nerves, the connective tissue, everything that keeps the tooth alive and responding.
So when infection reaches the pulp,
that's when the most intense pain often begins. Because the soft tissue is now inflamed, swelling, but it's trapped inside the rigid confines of the tooth. Pressure builds up. It gets very painful.
Okay, tough outer layers protecting the sensitive, vital core. But the tooth isn't just floating there. It's held in place by this complex support system the source calls the periodontium.
Absolutely. The periodontium is the foundation, the whole support apparatus. It includes the gingivae, the gums.
Right.
The alveolar bone, which is the part of the jawbone forming the tooth socket. Then there's the cementum covering the root surface, which we mentioned. And crucially, the periodontal ligament.
And what's special about that ligament?
The text describes it as tenaciously binding the cementum of the root to the alveolar bone. It's not a rigid fusion, it's more like a suspension system. It allows the tooth some slight movement, absorbs shock, keeps it anchored, and distributes the forces of chewing.
So it has a little give. It's not fused solid like say, a healed bone fracture.
Exactly. It's a dynamic connection.
And the gums themselves, the gingivae, they have different zones.
They do. You have the attached gingiva, which is firmly bound down to the underlying bone and tooth structure.
Right.
And then there's the free gingiva, which forms sort of a collar or cuff around the neck of the tooth.
Okay.
This free gingiva creates a shallow space, usually only about 1 to 3 millimeters deep in health.
Mm-hmm.
That space is called the gingival sulcus.
And the source specifically flags this sulcus as important. Why?
It really is. That small, shallow crevice around every single tooth is a natural trap. It's a niche for bacteria, food debris, plaque. As the source points out, the sulcus is precisely where many problems, both dental caries near the gum line and periodontal disease, tend to start their destructive processes if daily cleaning isn't effective at removing that accumulating plaque.
So understanding the structure of the sulcus helps us appreciate this inherent vulnerability.
Absolutely. It's a key battleground for oral health.
Okay, so we've got the tooth structure enamel, the sensitive dentin, the vital pulp, and the supporting periodontium gums, bone, that critical ligament, and the vulnerable sulcus. Now let's talk about the enemies of this system, starting with the big one. Dental caries.
Dental caries, tooth decay. Fundamentally, it's a destructive infectious process. And the source notes that early on, it's often asymptomatic. It progresses silently.
Which really underscores why regular dental checkups are so important, even if nothing hurts.
Precisely. You can have decay starting and not feel a thing. The whole process begins with bacteria, primarily one called Streptococcus mutans, living in the plaque biofilm on the tooth surface.
Plaque, that sticky film we all fight.
That's the one. It's this organic, buffering biofilm that constantly forms. If it's not removed effectively by brushing, flossing, and the natural cleansing action of saliva, these bacteria ferment dietary sugars.
Sugars from our food and drinks.
Right. And they produce acids as a byproduct.
And it's the acids that do the damage.
Yes. The acids demineralize the enamel. They literally dissolve the mineral structure, weakening it. The source identifies the most frequent sites for this attack. The pits and fissures on the chewing surfaces of back teeth.
Makes sense, they're hard to clean.
The smooth surfaces between teeth, where they touch if you're not flossing. Areas around existing fillings or crowns where margins might not be perfect. And exposed root surfaces, which become more common as we age due to gum recession. Cementum on the root isn't as hard as enamel.
So basically anywhere plaque can accumulate and be sheltered from brushing or saliva.
Exactly. So the acid weakens the enamel.
It eventually breaks through.
It weakens and eventually creates a breach, a cavitation, basically a hole. The decay process then extends into the underlying dentin. And once it's in the dentin, because of that exquisite sensitivity we discussed,
That's when symptoms usually start.
that's typically when the patient starts experiencing symptoms, pain, sensitivity.
And the symptoms change as the infection progresses deeper into the pulp.
They do. The source describes a progression. Initially, if the infection is just starting to irritate the pulp, it's called acute pulpitis, sometimes reversible pulpitis. The classic symptoms described here are sensitivity to percussion, like tapping on the tooth, or sensitivity to hot and cold.
Okay.
But here's a key diagnostic feature the source highlights for this early stage. The pain resolves immediately once the stimulus is removed.
So you drink something cold, it hurts, but the pain stops right away when you swallow.
Precisely. That quick stop is a strong indicator that the pulp, while irritated, might still be viable, maybe recoverable, reversible pulpitis.
Okay, pain that goes away fast might mean the pulp is still alive. But if it gets worse, if the infection isn't stopped,
Then it progresses. The infection spreads throughout the pulp tissue. This leads to irreversible pulpitis and eventually, if untreated, pulp necrosis, the death of the pulp tissue.
and the pain changes then.
Oh, yes. At the irreversible stage, the pain typically escalates significantly. The source describes it as severe pain, sharp, throbbing, sometimes more of a deep, visceral ache. And notably, it mentions the pain may be worse when the patient is lying down.
Why would lying down make a toothache worse? That seems counterintuitive.
It's thought to be related to changes in hydrostatic pressure within the blood vessels. When you lie flat, there can be a slight increase in blood flow and pressure to the head. Inside that inflamed, confined pulp chamber, that extra pressure can really exacerbate the pain signals from the nerves.
Makes sense. Horrible, but makes sense. So what happens when the pulp actually dies? Necrosis.
Once the pulp tissue dies, the pain character might change again. It could become constant or it might be intermittent. But a really crucial diagnostic clue mentioned is the loss of cold sensitivity.
Loss of cold sensitivity.
Right. The nerve endings in the pulp are dead. They no longer respond to cold stimuli. Heat might still cause pain due to gas expansion within the necrotic tooth, but the cold response is gone. That's a strong sign of necrosis.
Loss of cold sensitivity signifies necrosis, a dead tooth. So how do you manage these different stages according to the source?
Okay, for simple caries, decay that's still confined to the enamel or just into the early dentin, the treatment is straightforward. Remove the decayed tissue, clean the cavity, and restore the tooth. The source lists materials like amalgam, glass ionomer, composite resin, gold, standard fillings.
Right.
But once you reach irreversible pulpitis or pulp necrosis, the damage to the pulp is too extensive for just a filling. The source has the options and become root canal therapy.
The dreaded root canal.
Well, it's tooth saving. It involves meticulously cleaning out the entire infected pulp chamber and the root canals, disinfecting them thoroughly, and then filling that empty space, sealing it off. The alternative is extracting the tooth entirely.
So clean it out or pull it out. And failing to manage these infections properly, that can lead to serious complications, right?
They certainly can. An untreated infection at the root tip, a periapical infection, can lead to an abscess, a collection of pus. This often causes pain, specifically when chewing or biting down on that tooth.
Okay, that's localized, but it can spread.
Yes. The source describes how chronic, sometimes lower-grade infections can slowly erode into the surrounding alveolar bone, leading to osteomyelitis, a true bone infection.
That sounds serious.
It is, or the infection can find a path of least resistance and drain out through the gums, forming what's called a perulus, or commonly a gum boil. It looks like a little pimple on the gum near the infected tooth. It's essentially a draining sinus tract.
A perulus is a visible sign, but the infection can spread much more dangerously, can it?
Yes, and this is a critical takeaway from the source. The infection isn't always contained locally. It can track along the deep fascial planes of the head and neck.
Fascial planes, like layers of connective tissue.
Exactly. These tissue layers create pathways. An infection from a lower molar, for instance, can spread down into the submandibular space, the floor of the mouth. This can result in a condition called Ludwig's angina.
Ludwig's angina. I've heard that.
It's a virulent, rapidly spreading cellulitis. The source explicitly cross-references another chapter, emphasizing this is a life-threatening emergency because the swelling can quickly compromise the airway.
Wow, that's a huge jump in severity, really highlighting how a seemingly contained dental problem can explode into a systemic crisis. And the source provides a vital clinical warning about certain patient groups presenting differently.
Absolutely crucial point for mastery. It notes that elderly patients, individuals with diabetes, or patients taking glucocorticoid therapy may present with severe dental infections, even osteomyelitis or Ludwig's angina, with little or no pain or fever.
Really? No pain or fever with that kind of infection?
Their immune response might be blunted or their pain perception altered. So the absence of those classic alarm signs doesn't rule out a serious spreading infection in these vulnerable groups. It demands a higher index of suspicion from the clinician.
That's a key detail, knowing how patient factors can completely alter the classic presentation.
Okay, so that covers dental caries and its potential spread. The other major cause of tooth loss described in the source is periodontal disease.
Periodontal disease. Gum disease. It's a chronic inflammatory and infectious process, but this time it affects the tissue supporting the teeth, the periodontium we defined earlier.
And like caries, it starts with plaque.
Yes, it starts with bacterial plaque buildup, but specifically accumulating right at the gum line in that gingival sulcus. The source really emphasizes that plaque and its hardened calcified form, calculus or tartar, are preventable with diligent daily oral hygiene brushing and flossing and regular professional cleanings.
So if plaque isn't removed, it first causes inflammation of the gums. That's the first stage. Gingivitis. Undisturbed plaque triggers chronic inflammation. The signs described in the text are hyperareemia, which means redness and swelling of the free and attached gingivae and bleeding, particularly noticeable when brushing or flossing.
Is gingivitis reversible?
Often, yes. This early stage is generally reversible with improved oral hygiene and professional cleaning to remove the plaque and calculus buildup.
But if that inflammation isn't checked, if gingivitis is ignored,
that's when it can progress to the more destructive stage, severe periodontitis.
And what happens in periodontitis?
This is characterized by a deepening of that normal physiologic sulcus into pathological pockets around the teeth. There's destruction of the periodontal ligament, that crucial anchoring system we talked about.
So the tooth starts to lose its connection.
Exactly. There's progressive destruction of the entire periodontium, including the supporting alveolar bone itself. bone recedes. This leads to tooth loosening and, ultimately, if untreated, tooth loss. It's essentially a slow, chronic dismantling of the tooth support structure.
A gradual undermining. And the source mentions an intriguing potential systemic link for chronic periodontal disease. This connection keeps coming up.
It does. A potential role for chronic periodontal inflammation in promoting coronary heart disease and stroke has been proposed. The text cites epidemiologic studies showing a moderate but statistically significant association between chronic periodontal inflammation and atherogenesis, the process of plaque buildup in arteries.
That link between inflammation in the mouth and heart disease is fascinating.
It really is, and it speaks to this broader concept of systemic inflammation, how inflammation in one part of the body might influence processes elsewhere. However, it's important to note what the source actually says here.
Okay.
It's careful to state that a direct causal role for periodontal disease in cardiovascular disease remains unproven based on the evidence presented in this text. It's an observed association, it warrants further research, it's biologically plausible, but it's not presented here as a definitive cause and effect relationship.
Got it. Association, not necessarily causation, according to this source. Now, beyond the common chronic forms of periodontitis, there are also more acute and aggressive types mentioned.
Yes, these are less frequent but can be very destructive, often triggered by things like host stress or the introduction of particularly virulent pathogens into the oral environment. One dramatic example is acute necrotizing ulcerative gingivitis, or ANEO. It used to be called trench mouth.
Trench mouth, that name alone sounds pretty awful. What defines ANU?
It's characterized by a very sudden onset. You get painful gingival inflammation, ulceration, significant bleeding, and necrosis tissue death, specifically of the interdental papillae, the little triangles of gum tissue between the teeth.
Good.
And it's associated with a distinctive, really foul odor of fetid halitosis.
How is it managed?
The source mentions debridement, cleaning the area, and using hydrogen peroxide rinses can provide relief. Antibiotics might be needed for acutely ill patients, but it notes that ANU can recur, especially if underlying factors aren't addressed.
And then there's localized juvenile periodontitis. This is a particularly destructive form, seen specifically in adolescents. The source makes a specific connection here. It's often associated with impaired neutrophil chemotaxis.
Neutrophil chemotaxis. Okay, break that down. Neutrophils are key immune cells.
They're the first responders, a type of white blood cell. Chemotaxis is their ability to move towards a site of infection following chemical signals. So if neutrophil chemotaxis is impaired,
the body's initial defense against the bacteria building up in the gums is basically crippled.
Precisely. The neutrophils aren't getting to the battlefield effectively to fight the bacterial infection in the gingival sulcus and the developing pockets. This allows the destruction of the periodontal tissues to progress rapidly, even in young individuals who might otherwise seem healthy.
That makes sense. And finally, AIDS-related periodontitis is mentioned as another aggressive form.
Yes. In patients with advanced HIV infection and severe immunosuppression, periodontal disease can be particularly aggressive and destructive. It can resemble ANG, or it can look like a very rapidly progressing form of adult periodontitis. In the most severe cases of immunosuppression, it can even cause gangrene-like destruction of the oral soft tissues and bone, something the source compares to noma, a devastating facial gangrene seen in severely malnourished children.
Just devastating. It really highlights the crucial role of the immune system in keeping oral infections in check.
It absolutely does.
This all reinforces the importance of prevention. The source notes that prevalence of severe disease has reduced in the U.S., partly due to things like water fluoridation and better care, but it remains a major global health problem. And the internist, the general physician, has a role here, especially with high-risk patients.
A very important role. The source calls out specific populations identified as being at increased risk for poor oral health outcomes. These individuals may need targeted counseling, support, and perhaps more frequent monitoring.
Who's on that list?
It includes individuals with hyposalivation or xerostomia dry mouth because saliva is so protective, patients with diabetes, especially poorly controlled diabetes,
Okay.
alcoholics, tobacco users, both smoking and smokeless tobacco, individuals with Down syndrome, and patients experiencing drug-induced gingival hyperplasia. That gum overgrowth we'll probably touch on later.
And we also can't forget those facing systemic barriers to care, right?
Exactly. The source points this out clearly. Patients with low socioeconomic status who may lack access or resources. Individuals with physical or intellectual disabilities that make self-care difficult. Nursing home residents, people with dementia, or anyone with significant upper extremity disability limiting their ability to brush and floss effectively. These groups consistently show poorer oral health outcomes.
So what are the key counseling points internists can use to promote prevention based on this text?
The cornerstones are a regular professional dental cleaning and checkups. Consistent daily oral hygiene at home is paramount. Using a fluoride-containing toothpaste is highlighted. Professional fluoride treatments can offer additional protection, especially for those at higher risk.
What about tools?
For patients with limited dexterity, the source specifically mentions that electric toothbrushes can be significantly more effective than manual ones. And crucially, for patients who cannot perform their own care, maybe due to disability or dementia, instructing their caregivers on proper techniques is absolutely essential.
The source also realistically acknowledges barriers like cost, fear, language, and cultural differences.
Yes, and that's important. These are real-world challenges that absolutely impact access to dental services, especially preventive care. They contribute significantly to the disparities in oral health we see across different populations. Addressing these requires more than just clinical advice.
Definitely. Okay, moving beyond infections and inflammation like caries and periodontal disease, the source also covers developmental issues and how systemic diseases can leave their mark on the teeth and the periodontium.
Right. Malocclusion, which is basically misalignment of the teeth and jaws, is cited as the most common developmental problem.
Like needing braces.
Exactly. While it's often addressed for cosmetic reasons, the source notes that severe malocclusion can actually interfere with proper chewing, mastication, and may require orthodontic treatment or sometimes even corrective jaw surgery. Impacted third molars, wisdom teeth, are also very common. They can cause problems like infection or crowding if there isn't enough space for them to erupt properly.
And certain systemic conditions present during development can actually alter jaw size or tooth structure.
Yes, the source gives several clear examples. Acquired prognathism, where the lower jaw grows abnormally large and protrudes, can be a sign of acromegaly, excess growth hormone in adulthood. A receding chin and a protruding tongue might point towards congenital conditions like cretinism, congenital hypothyroidism, or hypopituitarism.
And syphilis again.
Congenital syphilis leaves very distinctive, almost pathognomonic signs on the permanent teeth if the infection occurs during their development.
Mm-hmm.
You get these tapered, notched incisors called Hutchinson's incisors and mulberry molars, which have poorly formed cusps, sort of nodular looking. Seeing those teeth is a huge clue to that past infection.
Those specific tooth shapes are clear signals. Then there's enamel hypoplasia defects in the enamel itself. The source lists a broad range of causes for this.
It does. Enamel hypoplasia means the enamel didn't form properly, resulting in defects that can range from subtle pits or lines to deep fissures or missing patches on the tooth crowns. The list of potential causes reflects disruptions during that critical window of enamel formation. Intra-outer infections like syphilis or rubella. Deficiencies in vitamins A, C, or D. Disorders of calcium metabolism, like malabsorption syndromes, vitamin D-resistant rickets, or hypoparathyroidism. Prematurity at birth. Even periods of high fever during childhood when enamel is developing. And then there are rare inherited conditions like amelogenesis imperfecta, where enamel formation is genetically faulty.
A lot of potential insults during development, and a classic drug-related cause is tetracycline antibiotics.
Yes, that's a well-known one. High doses of tetracycline or related antibiotics given to children before the age of 8 while their permanent teeth are still calcifying under the gums can cause enamel hypoplasia and, very characteristically, irreversible intrinsic discoloration. The teeth can look grayish or brownish.
But the source makes a very important exception here.
It does, and this is the crucial detail for clinical practice. It explicitly states that doxycycline, although it's in the same tetracycline class, does not appear to cause this permanent staining of developing teeth, despite the general warnings that often come with tetracycline use in children.
That is a really important distinction for prescribers to know. Doxycycline is okay in this regard. Other forms of tooth discoloration can come from systemic conditions where pigments actually get incorporated into the developing tooth structure.
Right. The source gives examples like erythroblastosis fetalis, a hemolytic disease of the newborn, which can lead to green or bluish-black tooth color. Congenital liver disease might cause green or yellow-brown staining. And porphyria, a metabolic disorder, can result in reddish-brown teeth that notably fluoresce under UV light.
And fluoride. We usually think of it as good for teeth.
It is, in the right amounts. But excessive fluoride exposure during enamel formation causes dental fluorosis, or mottled enamel. This can range from subtle chalky white spots or lines to severe brown staining and pitting of the enamel surface.
What about just wear and tear on the enamel over time?
Worn enamel can certainly occur simply due to age and decades of chewing, but it can be accelerated by bruxism, that involuntary grinding or clenching of teeth, often linked to stress or sleep disorders, and also by excessive acid exposure. The source specifically mentions chronic gastric reflux, where stomach acid comes up into the mouth, and bulimia, where repeated vomiting exposes teeth to stomach acid. This acid erosion typically affects the inner or lingual surfaces of the upper teeth most severely.
That pattern of erosion is a clue. The source also connects certain systemic conditions to increased tooth loss or loosening, often working through worsening periodontitis.
Yes. Beyond just common age-related periodontal disease, certain systemic conditions that affect immune function or connective tissues can predispose individuals to more severe or earlier onset periodontal breakdown and subsequent tooth loss. The examples given include cyclic neutropenia,
Where neutrophil counts drop periodically.
right, Papillon-Lefèvre syndrome, Chiari-Higashi syndrome, both rare genetic disorders affecting immune cells, and leukemia can also worsen periodontal status.
What about rapid loosening of just one or a few teeth?
While that's often due to a localized infection, like an abscess, the source warns that rapid focal tooth loosening can rarely be a sign of something more sinister, like malignant infiltration of the jawbone. It lists possibilities such as Langerhans, cell histiocytosis, Ewing sarcoma, osteosarcoma, or Burkitt's lymphoma. So, sudden loosening needs investigation.
An early loss of primary teeth, baby teeth, can signal a rare metabolic disorder.
Yes, the source mentions that premature shedding of deciduous teeth, sometimes starting even in infancy, is a key feature of hypophosphatasia. This is a rare congenital error of bone and mineral metabolism.
Okay. Focusing specifically on the gums again, the gingivae, they can show distinctive signs of systemic illness or changes.
They certainly can. Pregnancy, for instance, is commonly associated with pregnancy. Gingivitis, increased inflammation and bleeding due to hormonal changes. Sometimes localized growths called pyogenic granulomas can also appear on the gums during pregnancy.
And diabetes.
Uncontrolled diabetes mellitus is strongly linked to more severe and rapidly progressing periodontal disease. Managing blood sugar is critical for oral health in these patients.
Certain medications are well known for causing the gums to actually overgrow.
Yes, drug-induced gingival hypoplasia, or overgrowth. This is a common side effect associated with certain classes of drugs. The text lists anticonvulsants, particularly phenytoin.
Lanting.
Right. Calcium channel blockers used for blood pressure, like nifedipine, and immunosuppressants, such as cyclosporine, often used after organ transplants.
Can anything be done about this gum overgrowth?
The source offers a crucial clinical note here. Maintaining excellent daily oral hygiene can significantly prevent, or at least reduce, the severity of this drug-induced overgrowth. Meticulous plaque control is key. Discontinuing the offending drug, if possible, may lead to reversal of the overgrowth over time. However, in severe cases, or for similar conditions that are genetic, like idiopathic familial gingival fibromatosis, surgical removal of the excess gum tissue might be necessary.
Good hygiene can make a difference, even with those drugs. Are there any other particularly distinctive gingival signs linked to specific diseases mentioned?
Yes, a few notable ones. Linear gingival erythema. It presents as a distinct fiery red band right along the margin of the gingiva. This is often seen in patients with advanced HIV infection and is thought to reflect the underlying immune deficiency, likely related to reduced neutrophil function or altered microbial flora.
Okay, a red line along the gums in HIV.
Diffuse or focal gingival swelling or infiltration of the gums, looking generally enlarged or having specific lumps, can sometimes be a manifestation of leukemia, especially acute myelomonocytic leukemia, AMML, or other lymphoproliferative disorders infiltrating the gum tissue.
And the really striking one.
Ah, yes. The source mentions a rare but very striking, almost pathognomonic sign associated with granulomatosis with polyangiitis, formerly Wegener's. It's a specific type of gingivitis described as looking like strawberry gums, intensely red or purplish, swollen, and granular looking. Seeing that should definitely raise suspicion for GPA.
Strawberry gums, that's definitely memorable. It really underscores how important it is for clinicians to look closely inside the mouth. Okay, let's transition now from the teeth and their supporting structures and systemic effects on them to diseases that primarily affect the oral mucosa, the soft tissue lining of the mouth.
Right, the lining of the cheeks, lips, palate, tongue, floor of mouth. As the source notes, A lot of diseases affecting the oral mucosa involve microorganisms, and probably the single most common type of lesion seen here is ulceration.
So when a patient presents with an oral ulcer, how do you even begin to approach the differential diagnosis? There must be many causes.
There are many. The text indicates that differentiating the cause relies on several factors, looking at host factors like immune status, age, medications, assessing the specific pattern and appearance of the lesion or lesions, are they single, multiple, shallow, deep, recurrent, and critically looking for the presence of other clinical features or symptoms elsewhere in the body that might point to a systemic condition.
Makes sense. What about typical acute ulcers?
Acute ulcers tend to be painful, but self-limited, they heal on their own. The source states the most common causes by far are recurrent aphthous ulcers.
Canker sores.
Exactly, canker sores, and infections with herpes simplex virus, HSV.
What about ulcers that are more persistent or maybe deeper?
Persistent or deep aphthous ulcers, sometimes called major aphi, can occur idiopathically, meaning without a known cause. But they are also notably seen in patients with HIV/AIDS. And here's a critical point. They are often the presenting symptom of Behçet syndrome, a systemic inflammatory vasculitis.
So seeing those ulcers should trigger thoughts of Behçet's.
Definitely. The text also mentions that similar-looking lesions can appear in reactive arthritis, formerly Reiter's syndrome, and, less commonly, in discoid or systemic lupus erythematosus, SLE. And aphthous-like ulcers are also described as occurring in Crohn's disease, another inflammatory condition.
And the source mentions another specific connection for recurrent apthi, linking back to something we discussed earlier.
Yes, it makes a specific connection to celiac disease. Recurrent aphthous ulcers are noted to be more prevalent in patients with celiac disease, and importantly, these ulcers may actually remit or get much better after gluten is eliminated from the diet.
Another fascinating mouth-gut connection.
It really is.
Now, there's a critical time frame mentioned. When an oral ulcer or a certain kind of patch lasts for a specific duration, it raises a major red flag.
Absolutely crucial point here. Chronic, relatively painless ulcers, or mixed red and white patches. The source uses the terms erythroplakia for velvety red patches and leukoplakia for white patches that persist for more than 2 weeks. That duration is key.
2 weeks?
Yes. More than 2 weeks demands a high index of suspicion for malignancy, specifically squamous cell carcinoma or potentially premalignant dysplasia, meaning abnormal cell changes that could turn into cancer.
So, persistence beyond 2 weeks is the critical cutoff time to trigger high suspicion and prompt action.
Exactly. The source strongly emphasizes that early biopsy is critical for these persistent, suspicious lesions. Early detection of oral cancer leads to significantly better treatment outcomes and prognosis. Waiting is dangerous.
Are there specific locations within the mouth where oral cancer is more likely to develop? High-risk zones.
The text lists several high-risk sites for squamous cell carcinoma. These include the lower lip, especially related to sun exposure, the floor of the mouth, the ventral underside and lateral side surfaces of the tongue, and the area where the soft palate meets the tonsillar pillars.
And what are the major risk factors highlighted in the source for developing these cancers?
In Western countries, the major risk factors cited are chronic sun exposure, particularly for cancer of the lower lip, tobacco use, both smoked and smokeless forms, excessive alcohol consumption, especially in combination with tobacco use, which has a synergistic effect, and increasingly recognized, infection with certain strains of human papillomavirus, HPV, particularly for oropharyngeal cancers.
And the source points out regional differences in risk factors, too.
Yes, it highlights that in parts of India and Southeast Asia, the widespread cultural practice of chewing smokeless tobacco mixtures, often containing betel nut, slaked lime, and various spices, is a major driver of oral cancer. So risk factors can vary geographically.
Okay. Beyond malignancy, what are some rare causes of chronic ulcers that might look like cancer initially?
The differential diagnosis for a chronic oral ulcer that mimics carcinoma includes certain infections, like tuberculosis, which can cause oral ulcers, usually secondary to lung infection, and deep fungal infections, like histoplasmosis or blastomycosis. Certain inflammatory conditions can also present this way, such as granulomatosis with polyangiitis or midline granuloma, a destructive process often related to lymphoma. Distinguishing these usually requires identifying other systemic features of the underlying condition and, again, almost always relies heavily on biopsy for a definitive diagnosis.
The primary syphilitic chancre in the mouth is also mentioned, with a key characteristic that can make it easy to miss.
Yes, the source points out that the oral chancre of primary syphilis is typically painless.
Painless? That's true.
It is.
This lack of pain means it can be easily overlooked by the patient, especially if it's in a less visible area like the back of the throat. However, the text notes it is invariably associated with regional lymphadenopathy, swollen lymph nodes in the neck. Diagnosis is confirmed through specific bacterial examination, like dark field microscopy if available, or serologic blood tests for syphilis.
Finally, some types of ulcers result from conditions that actually make the oral lining itself fragile and prone to breakdown.
Right, these are disorders characterized by mucosal fragility. The major acquired autoimmune blistering disorders mentioned are mucous membrane pemphigoid, also called cicatricial pemphigoid, and pemphigus vulgaris.
What do those cause?
They cause painful blisters and erosions on the oral mucosa, and often other mucous membranes like the eyes or genitals or skin and pemphigus. These ulcers fail to heal normally and can persist for a long time. Distinguishing these serious autoimmune conditions from other inflammatory issues like erosive lichen planus or severe drug reactions often requires a biopsy for routine histology and special immunofluorescence studies to detect the characteristic autoantibodies in the tissue.
Okay, complex diagnosis needed there. The source includes tables that summarize many of these oral mucosal lesions, including a whole range of specific infections. Let's maybe touch on some key examples from Table 36-1, just to get a flavor.
Sure. Table 36-1 details various infectious causes. For viral infections, it mentions primary acute herpetic gingivostomatitis. This is the first time someone gets infected with HSV-1, usually in childhood or young adulthood.
What does that look like?
It's described as typically very painful, with widespread vesicles, blisters, and ulcers throughout the mouth and lips, accompanied by acute gingivitis, fever, malaise, and swollen neck lymph nodes. It usually heals on its own, but takes about 10 to 14 days.
And then there's recurrent herpes.
Yes. After the primary infection, the virus lies dormant. Recurrent herpes labialis is the common cold sore, typically appearing on the vermilion border of the lip. Recurrent intraoral herpes is less common, but presents as clusters of small, painful ulcers, specifically on attached keratinized tissue like the hard palate or the attached gingiva. Both are caused by HSV reactivation and usually heal spontaneously in about a week or so.
Chickenpox and shingles, herpes zoster, are both caused by the varicella zoster virus, VZV. Do they show up in the mouth?
Chickenpox, primary VZV infection, can cause a few small scattered oral ulcers along with the typical skin rash. Herpes zoster, or shingles, is the reactivation of that dormant VZV, usually later in life, when it affects the trigeminal nerve branches supplying the mouth.
The nerve for facial sensation.
Right. It causes a unilateral, one-sided eruption of painful vesicles and ulcers, typically following the nerve's distribution on the cheek lining, tongue, or palate. The source notes that oral antiviral medications, like valacyclovir, started early can shorten the duration and may reduce the risk of postherpetic neuralgia, which is persistent nerve pain after the rash heals.
Infectious mononucleosis caused by Epstein-Barr virus, EBV, also have oral signs. The source mentions a specific timing clue.
It does, and it's a useful clinical pearl. Mono presents with the classic fatigue, sore throat, fever, and swollen lymph nodes. But the source notes that numerous small oral ulcers, sometimes on the palate or throat, often appear several days before the characteristic widespread lymphadenopathy develops. Seeing those early ulcers can be a hint. Petechiae, small red spots on the palate, are also common in mono.
Coxsackie viruses cause a couple of well-known childhood illnesses with oral lesions.
Right. Herpingina, typically seen in young children, often in summer or early fall. It causes sudden onset of fever, sore throat, and small vesicles that quickly ulcerate, located specifically in the posterior part of the mouth, the soft palate, uvula, tonsillar pillars.
And hand, foot, and mouth disease.
Also typically affects young children, caused by a different Coxsackie virus strain, usually A16. It presents with fever, malaise, and then vesicles and ulcers in the mouth, plus characteristic vesicles on the palms of the hands and soles of the feet. Both herpingina and hand, foot, and mouth are generally self-limited viral illnesses.
And primary HIV infection itself can present acutely with oral signs.
Yes. During the initial seroconversion illness, that acute febrile mono-like syndrome that occurs shortly after acquiring HIV patients can develop acute gingivitis and sometimes oropharyngeal ulceration. These oral signs might be part of that initial presentation.
Okay, moving to bacterial and fungal infections listed in Table 36-1. We already discussed AUG, trench mouth. What else stands out?
Well, syphilis comes up again. The primary syphilitic chancre is described as a key bacterial ulcer, typically large, painless, firm, indurated, with significant regional lymphadenopathy, often occurring on the lips or tongue.
And secondary syphilis.
Secondary syphilis, which occurs weeks to months later, classically presents with mucus patches. These are grayish-white, slightly raised patches or shallow ulcers on the mucous membranes, teeming with spirochetes and highly infectious. Tertiary syphilis, much rarer now, can cause destructive gummas, granulomatous lesions, or diffuse inflammation of the tongue, glossitis.
Gonorrhea.
Gonorrhea can cause pharyngeal infection, often acquired through oral sex. It might cause a sore throat, but the source notes it's frequently asymptomatic. Oral lesions are less common, but can occur.
Tuberculosis.
Oral tuberculosis is uncommon in developed countries, but can occur, usually secondary to pulmonary TB through infected sputum. It typically presents as a solitary, irregular, often somewhat painless ulcer, maybe on the tongue or palate. Biopsy and culture are needed.
And cervicofacial actinomycosis has a pretty unique appearance described.
It does. Actinomycosis is a bacterial infection caused by Actinomyces species, which are actually normal oral flora. It typically presents as a hard, slowly developing swelling, often around the angle of the jaw, hence lumpy jaw. It can form draining sinus tracts to the skin surface. The characteristic finding mentioned is the presence of yellowish sulfur granules in the pus. These are actually visible colonies in the bacteria. It's often associated with recent dental procedures or trauma that allow the bacteria to invade deeper tissues. Requires long-term antibiotics.
And histoplasmosis as a fungal cause of ulcers.
Yes, oral lesions can occur in disseminated histoplasmosis, especially in immunocompromised individuals. They might present as nodular, ulcerated, or vegetative lesions that can mimic malignancy. Diagnosis requires biopsy and fungal staining culture. Needs systemic antifungal treatment. Candidiasis is mentioned generally here as a cause of mucosal disease, but the specific types are detailed more in Table 36-3 on white lesions.
Okay, let's look at Table 36-2 then, which focuses specifically on pigmented lesions of the oral mucosa. Some are common and benign, but malignancy is always a concern with pigment.
Right. The table lists several possibilities. Oral melanotic macules are common, benign, flat brown, or black spots, like freckles on the mucosa. They usually remain indefinitely. Diffuse melanin pigmentation can be physiologic, just normal racial pigmentation, common in individuals with darker skin tones. It can also be related to smoking, smoker's melanosis.
Nevy, like moles.
Exactly. Oral nevy moles can occur. They're localized, usually raised, brown or black spots. Most are benign, but like skin moles, they have a very small potential for malignant transformation, so sometimes biopsy is done for confirmation. The crucial one, though, is malignant melanoma.
Oral melanoma. That sounds bad.
It is. Primary oral melanoma is rare, but highly aggressive. It can present as a flat, spreading patch or a raised, sometimes ulcerated nodule. It's often painless in the early stages. It tends to expand, invade locally, and metastasize early. The source emphasizes that early detection and biopsy are absolutely vital for any chance of successful treatment. Any unexplained or changing pigmented lesion needs evaluation.
Are there systemic conditions that cause oral pigmentation?
Yes. Addison's disease, adrenal insufficiency, classically causes patchy, bluish-black or dark brown blotches on the buccal mucosa inside the cheeks, often appearing early in the disease, usually along with generalized skin hyperpigmentation.
Okay.
Peutz-Jeghers syndrome is a genetic condition characterized by distinctive small, dark brown spots, like freckles, concentrated around the lips, nostrils, and eyes, as well as on the oral mucosa. This is important because it's associated with intestinal polyposis, and those polyps have an increased risk of becoming malignant.
So the mouth spots are a clue to look at the gut.
Exactly. Certain drugs can also cause oral pigmentation. The source lists neuroleptics, oral contraceptives, the antibiotic minocycline, the HIV drug zitavudine, AZT, and quinine derivatives. The pigmentation is often brown, black, or grayish and may disappear after stopping the drug.
What about those blue-black spots you sometimes see near fillings?
Ah, the amalgam tattoo. That's very common. It results from tiny particles of silver amalgam filling material getting accidentally embedded in the gum tissue, usually during a filling placement or removal. They appear as localized blue-black or gray spots, typically on the gingiva or alveolar mucosa near a restored tooth. They're completely benign. Sometimes they even show up on an X-ray as tiny radiopaque flecks.
Heavy metal exposure used to be a cause.
Yes. Historically, chronic exposure to heavy metals like bismuth, used in old medications, mercury, or lead could cause a thin blue-black line along the gingival margin called a Burton's line for lead. It's rare now, but might still be seen with significant lead exposure.
Black hairy tongue sounds alarming.
It looks dramatic, but is benign. It's caused by elongation of the filiform papillae, the tiny projections, on the top surface of the tongue, which then gets stained by coffee, tea, tobacco, or pigment-producing bacteria. Looks like a dark, hairy mat. Improving oral hygiene, especially brushing the tongue, and stopping antibiotics if they triggered bacterial overgrowth usually helps.
Fordyce spots.
Also very common and totally benign. These are small, yellowish spots, often slightly raised, usually seen on the buccal mucosa or lips. They're simply collections of normal sebaceous oil glands that happen to be in the oral lining.
Kaposi's sarcoma is mentioned as a pigmented lesion too.
Yes, Kaposi's sarcoma, KS, a vascular tumor strongly associated with immunosuppression, particularly HIV/AIDS, often presents as reddish-purple or bluish vascular plaques or nodules. The palate is a very common site for oral KS. The lesions often enlarge and may ulcerate. Seeing KS usually indicates underlying HIV or sometimes other conditions like non-Hodgkin's lymphoma.
And mucus retention cysts.
These are common benign swellings, often appearing bluish and translucent, typically on the lower lip. They're caused by blockage or rupture of a minor salivary gland duct, leading to pooling of mucus under the lining, also called mucosal, usually painless unless they get irritated.
Okay, that covers a lot of pigmented possibilities. Now let's look at Table 36.3, which details white lesions of the oral mucosa. Candidiasis, or thrush, is probably the most recognized one.
It is. Candidiasis comes in several forms. The classic one is pseudomembranous candidiasis, or thrush. It presents as creamy white, curd-like patches on the mucosa that can be scraped off, often revealing a red, sometimes bleeding surface underneath.
Who gets thrush?
The source mentions sick infants, debilitated elderly individuals, people on high-dose inhaled or systemic steroids, those taking broad-spectrum antibiotics, and patients with immunodeficiency, especially AIDS.
Are there other forms of oral candidiasis?
Yes. Erythematous candidiasis presents as flat, red, often sore areas, particularly on the palate of a rodenture or on the tongue, where it causes loss of papillae. It affects the same high-risk groups. Candida leukoplakia, or chronic hyperplastic candidiasis, is a less common form that appears as a white patch that cannot be scraped off, caused by candida invading the epithelium. An angular cheilitis consists of soreness, redness, and fissuring at the corners of the mouth, often involving both candida and bacteria.
How is candidiasis treated?
Treatment involves topical or systemic antifungal medications, like nystatin, clotrimazole, fluconazole. But just as importantly, it requires addressing the underlying predisposing factors, optimizing denture hygiene, managing diabetes, adjusting steroid or antibiotic use if possible, treating immunodeficiency.
Okay, what are some other significant white lesions listed in Table 36-3?
Lichen planus is a common chronic inflammatory condition. Orally, it can present in several ways, most classically as Wickham's striae fine, white, lace-like lines, often on the buccal mucosa. It can also form white plaques, red atrophic areas, erosive lichen planus, or even painful ulcers. It may be asymptomatic or cause significant soreness or burning. Lichenoid drug reactions can look identical. It's chronic, often waxing and waning, and symptomatic cases usually respond to topical glucocorticoids.
White sponge nevus.
This is a rare inherited condition causing painless, widespread, thickened, white corrugated patches on the oral mucosa, usually present from childhood. It's benign.
What about white patches linked to tobacco?
Smokers' leukoplakia, smokeless tobacco keratosis present as white patches on the mucosa related directly to tobacco use at the site of contact. These are usually painless initially. They represent a tissue reaction to the chronic irritation. The key concern is that these lesions carry an increased risk. The source says about 2% of undergoing malignant transformation into squamous cell carcinoma over time.
So they need monitoring.
Absolutely. Early biopsy is often recommended, especially if they look thickened or have any red areas mixed in. Stopping the tobacco habit may lead to resolution of the lesion, but not always, and the cancer risk persists. Close follow-up is essential.
Erythroplakia is mentioned again here, sometimes with white patches.
Yes, erythroplakia, those velvety reddish plaques, can occur alone or mixed with white areas, erythroleukoplakia. The source emphasizes again that these lesions have a very high risk of harboring invasive squamous cell cancer or severe dysplasia. Early biopsy is mandatory. The location can vary. The text notes floor of mouth is common in men, tongue in women.
Hairy leukoplakia sounds similar but is different.
Very different. Hairy leukoplakia specifically occurs on the lateral borders of the tongue, appearing as white, corrugated, or hairy-looking areas that cannot be scraped off. It's strongly associated with HIV infection, though can occur in other immunosuppressed states, and is caused by opportunistic infection with the Epstein-Barr virus, EBV, within the epithelial cells. It itself is benign, but serves as a marker for immunosuppression. The source notes it responds to high dose of cyclover, but often recurs when the drug is stopped.
Warts in the mouth.
Oral warts, caused by HPV infection, can occur. They might look like typical papillary, cauliflower-like growths, condyloma or papilloma, or sometimes flatter, pinkish bumps, focal epithelial hyperplasia. They can grow and spread. Biopsy is important to confirm the diagnosis and rule out squamous cell carcinoma, which can sometimes look similar. Treatment usually involves excision or laser ablation. Interestingly, the source mentions they may regress with effective antiretroviral therapy in HIV patients.
Okay. Table 36-5 then basically summarizes many of the oral manifestations specifically linked to HIV disease and AIDS, many of which we've just touched upon, really emphasizing how immunosuppression dramatically impacts the mouth.
Exactly. It brings together things like the various forms of candidiasis, pseudomembranous, erythematous, hyperplastic, angular cheilitis, the risk of non-Hodgkin's lymphoma presenting orally, hairy leukoplakia, severe recurrent aphthous ulcers, the aggressive periodontal diseases, AG, necrotizing periodontitis, even necrotizing stomatitis, increased susceptibility to viral infections, HSV, VZV, CMV, opportunistic fungal and mycobacterial infections, certain bacterial infections, drug reactions like zidovudine pigmentation, Kaposi sarcoma, bacillary haematologic, and that linear gingival erythema. It's a stark picture of how profound immune deficiency manifests orally.
It really is. Certain general dermatologic diseases also have prominent oral components, as hinted at in these tables. Can we quickly revisit those connections?
Sure. Mucous membrane pemphigoid, as mentioned, causes painful gingivitis, blistering, and scarring, primarily affecting mucous membranes, including the mouth. Erythema multiforme, including its severe form Stevens-Johnson syndrome, SJSN, often involves painful oral erosions and crusting of the lips, along with characteristic target skin lesions. It's frequently triggered by infections or drugs and can be life-threatening.
Pemphigus vulgaris.
Pemphigus vulgaris, another serious autoimmune blistering disease, often starts with fragile oral blisters and erosions that can precede skin lesions by months. The oral lesions are often widespread and painful, and lichen planus, which we discussed as a white lesion, can also have associated skin lesions, purplish, itchy bumps, or affect other sites like the genitals or nails. Again, biopsy, often with immunofluorescence, is crucial to distinguish these conditions accurately.
Okay. Hematologic problems and nutritional deficiencies also leave telltale signs in the mouth. Bleeding is a big one.
Yes. Bleeding disorders, whether congenital or acquired, which are more common, can manifest with excessive oral bleeding. The source gives some useful benchmarks. Bleeding from minor oral trauma should stop within 15 minutes, and bleeding after a tooth extraction should be controllable within about an hour with pressure. Prolonged or uncontrollable bleeding warrants investigation for an underlying clotting abnormality.
What about bruising?
Petechia, tiny red spots, and ecchymoses, larger bruises, on the oral mucosa, particularly prone to occur at the vibrating line. The junction of the hard and soft palate can be signs of platelet dysfunction or thrombocytopenia, low platelet count. That location is susceptible due to minor trauma during swallowing or speech.
Leukemia can have quite striking oral manifestations.
It certainly can. All forms of leukemia, but especially acute myelomonocytic leukemia, AMML, can cause significant gingival bleeding, spontaneous bruising, oral ulcers, marked gingival enlargement due to leukemic cell infiltration, tissue necrosis, and hemorrhage. These oral signs can sometimes be the first indication of the underlying leukemia.
Other blood count issues.
Oral ulcers are also a common and painful feature of a granulocytosis, severe lack of neutrophils. And severe painful mucositis and ulceration are very common side effects of chemotherapy and radiation therapy used to treat malignancies, due to the damage to the rapidly dividing cells of the oral lining.
Plummer-Vinson syndrome is mentioned as a triad with increased cancer risk.
Yes, Plummer-Vinson syndrome consists of iron deficiency anemia, glossitis, inflammation of the tongue, often smooth and sore, angular stomatitis, cracks at the corners of the mouth, and dysphagia, difficulty swallowing, often due to esophageal webs. The source highlights that this syndrome significantly raises the risk of developing oral squamous cell cancer and postcricoidal esophageal cancer. So recognizing it is important for cancer surveillance.
And specific vitamin deficiencies affect the tongue and mucosa.
Pernicious anemia, vitamin B12 deficiency, classically causes atrophic glossitis. The tongue papillae shrink, leaving the tongue looking smooth, red, beefy, and often feeling sore or burning. Other B-group vitamin deficiencies, like riboflavin, niacin, folate, can cause similar symptoms, plus sometimes ulceration and chylosis, inflammation and cracking of the lips and corners of the mouth. Scurvy, severe vitamin C deficiency, now rare but still seen, leads to swollen, spongy, bleeding gums, ulcerations, and eventually loosening of teeth due to breakdown of periodontal ligament collagen.
just incredible how much the mouth reflects our overall systemic status. Now let's shift gears slightly to talk about oral pain that isn't originating from a tooth or gum issue itself. The source notes these non-dental causes are often overlooked.
This is a really key differential diagnosis to keep in mind. Most pain felt in the mouth or jaw is dental or periodontal in origin, and that pain usually follows a predictable pattern. It's provoked by certain stimuli, hot, cold, biting, it's localized to a specific area, and it's linked to an identifiable condition like caries, pulpitis, or an abscess.
And the source mentions a crucial diagnostic test.
Yes, the use of local anesthetic. Injecting local anesthetic around the suspected tooth or area will effectively eliminate pain originating from dental or periodontal structures. However, it will not abolish referred pain or pain originating from neuropathic sources. That distinction is incredibly useful clinically.
So if the pain persists despite adequate local anesthesia, you have to think outside the tooth. What are some common non-dental sources of pain felt in the mouth or jaw?
Myofascial pain is very common. This is pain referred from the muscles of mastication, the chewing muscles. Patients often describe tenderness in the muscles and ache that worsens with chewing or jaw use. This is frequently associated with bruxism, grinding or clenching, which the source links in turn to stress and anxiety.
And temporomandibular joint, TMJ disorder, is related?
Closely related. TMJ disorder involves the jaw joint itself and/or the surrounding muscles. Features include pain in the joint area, just in front of the ear, limited jaw movement, difficulty opening wide, and it sounds like clicking or popping from the joint. The source notes its etiology is complex, often multifactorial, and importantly, malocclusion, bad bite, is not considered the primary driver as was once widely believed. Osteoarthritis of the TMJ is listed as a common cause of joint-related pain.
How is TMJ pain typically managed according to the text?
Initial management focuses on conservative measures, anti-inflammatory medications like NSAIDs, resting the jaw, avoiding hard or chewy foods, and applying heat to the affected area. The source adds an interesting point. TMJ involvement can sometimes be a late feature of certain severe systemic inflammatory diseases, like rheumatoid arthritis, and it describes bilateral preauricular pain, pain in front of both ears, worse in the morning and limiting the range of motion, as a notable feature in those cases.
Okay, moving from musculoskeletal causes to nerve-related pain. Neuropathic pain can also manifest in the mouth or face.
Absolutely. Migrainous neuralgia, a type of headache syndrome, can rarely localize exclusively to the mouth or teeth. It typically occurs in cycles of pain and remission, without any identifiable oral cause, and crucially, the pain is not relieved by local anesthesia. That's a key clue.
Then there's the classic trigeminal neuralgia.
Doloro. This is characterized by episodes of sudden severe lancinating, shooting, or stabbing pain in the distribution of one or more branches of the trigeminal nerve, cranial nerve V, usually the maxillary or mandibular branches supplying the teeth, gums, cheek, or chin. The pain is often triggered by light touch to a specific trigger zone, like the lip or gum, or by actions like brushing teeth, chewing, or even talking.
Glossopharyngeal neuralgia affects a different nerve pathway.
Yes, this involves the glossopharyngeal nerve, cranial nerve IX. The pain is similar in quality sharp, shooting, but occurs in the nerve's distribution. The base of the tongue, the pharynx, the soft palate. It's often triggered by swallowing, sneezing, coughing, or sometimes pressure on the tragus of the ear. Interestingly, the source notes this pain can be referred to the TMJ area.
So it can mimic TMJ pain.
It can. Neuritis or inflammation of the trigeminal nerve branches themselves, for example, due to maxillary sinusitis invading the nerve, a neuroma, or leukemic infiltration, can also cause pain that might mimic a toothache, but often has a more constant burning or tingling neuropathic quality. Phantom pain, pain felt in the area where a tooth used to be, can occasionally occur after an extraction.
What about shingles affecting facial nerves?
Herpes zoster shingles, involving either the facial nerve, CN7, causing Ramsay-Hunt syndrome, or the trigeminal nerve, CNV, can cause significant pain. The source notes that pain and hyperalgesia, increased sensitivity behind the ear or on the side of the face, can occur before any facial weakness in Ramsay-Hunt, or visible shingles rash appears, and persistent postherpetic neuralgia can follow the acute infection.
Pain can also be referred to the mouth or jaw from completely different body systems. This seems really important to recognize.
Critically important. A prime example given is coronary ischemia heart pain. The source emphasizes that angina or even a heart attack can present exclusively as pain felt only in the face or jaw without any chest pain. Like typical angina, this referred pain might be reproducible with exertion or stress that increases myocardial oxygen demand. Recognizing this possibility is vital to avoid missing a cardiac emergency.
Absolutely vital. Another example.
Maxillary sinusitis. Inflammation or infection in the maxillary sinus, located just above the upper back teeth, often causes an aching pain felt in several upper molar or premolar teeth on that side. A key diagnostic clue here is that the pain is unrelieved by anesthetizing the affected teeth. The source of the pain isn't the teeth themselves.
That lack of relief from local anesthetic is the giveaway again. Any other systemic conditions mentioned that can cause referred facial or oral pain?
Giant cell arteritis, temporal arteritis, which is famous for causing headache, can also present with facial pain or sore throat without a headache. Jaw claudication, pain in the jaw muscles with chewing or talking, is relatively common in GCA. Tongue claudication or even infarction, tissue death due to lack of blood flow, is rarer but can occur.
Okay.
Subacute thyroiditis, inflammation of the thyroid gland, can also cause pain referred to the face or jaw, sometimes appearing before any tenderness over the thyroid gland itself or signs of transient hyperthyroidism become apparent.
Fascinating referrals. Finally, the source addresses burning mouth syndrome.
Yes, also called glossodynia or oral dysesthesia. This is defined as a burning or painful sensation in the mouth, often affecting the tongue, lips, or palate, but occurring without any identifiable clinical abnormality or underlying medical cause like a vitamin B12 or iron deficiency, undiagnosed diabetes, low-grade candida infection, food sensitivity, or subtle dry mouth.
So it's a diagnosis of exclusion.
Largely, yes. It predominantly affects postmenopausal women. The etiology isn't fully understood, but the source suggests it may be neuropathic in origin, a problem with nerve signaling or processing.
Is there any effective treatment mentioned?
It can be difficult to treat. The source mentions that treatments showing some benefit in studies include low-dose clonazepam, a benzodiazepine, alpha-lipoic acid, an antioxidant, and cognitive behavioral therapy. It also notes a specific potential link. Some cases have been associated with the use of ACE inhibitors, blood pressure medications, and the burning reportedly remitted upon discontinuing the drug.
So it's always worth reviewing medications. It's clear that a thorough investigation is needed for oral pain, looking well beyond just the teeth and gums. Let's shift now to diseases affecting the salivary glands, starting with why saliva itself is so important.
The source really highlights saliva's essential role in maintaining oral health. It lists several key functions: cleansing the mouth by washing away food debris and bacteria, illuminating the tissues for comfortable speech, chewing, and swallowing, providing antimicrobial factors.
Like what?
It lists lysozyme, lactoperoxidase, and secretory IgA antibodies, all of which help control the oral microbial population. Saliva also contains epidermal growth factor, which aids in mucosal healing, delivers minerals like calcium and phosphate to help remineralize early enamel lesions, and provides buffering capacity to neutralize acids produced by plaque bacteria.
So it's much more than just spit. Reduced salivary flow, hyposalivation leading to the sensation of xerostomia or dry mouth must have significant consequences then.
Major consequences. The subjective feeling of dry mouth, xerostomia, is typically perceived when the total unstimulated salivary flow rate is reduced by about 50%. This reduction dramatically increases the risk for rampant dental caries, especially root caries, and periodontal disease. It also makes wearing dentures uncomfortable or difficult, interferes with normal mastication and swallowing, and can even impair speech.
What are the main culprits behind dry mouth?
By far the most common cause cited is medication side effects. Hundreds of drugs can cause dry mouth. The text specifically mentions anticholinergic drugs, but also alpha and beta blockers, calcium channel blockers, diuretics, antidepressants, antihistamines. The list is long.
Beyond drugs.
Other common causes include Sjogren's syndrome, which is an autoimmune disease that attacks the salivary and lacrimal glands, chronic inflammation or infection of the glands, parotitis, obstruction of salivary ducts, perhaps by stones, conditions like poorly controlled diabetes, HIV/AIDS, and, significantly, radiation therapy to the head and neck region, which can permanently damage salivary gland tissue within the radiation field.
How is hyposalivation managed, based on the guidance in the text?
Management is multifaceted. First, identify and, if possible, eliminate or limit any offending medications that cause drying. Second, focus heavily on preventive dental care to mitigate the increased risk of caries and periodontal disease. This includes meticulous hygiene and frequent professional care. Using oral liquids frequently or specific salivary substitutes can provide moisture and lubrication.
Can you stimulate more saliva?
If there's still some residual functional gland tissue, salivary secretion can be stimulated. The source suggests using sugarless mints or chewing gum. For more significant dysfunction, pharmacologic agents like pilocarpine or cevimeline,
cholinergic agonists, can be prescribed to stimulate secretion, provided some exocrine tissue remains. Commercial saliva substitutes or gels can help with lubrication. And critically, the source emphasizes that fluoride supplementation, often via prescription high-fluoride toothpaste or rinses, is mandatory to prevent the severe caries associated with chronic dry mouth.
Okay, silolithiasis is the technical term for salivary stones. How do they present?
Salivary stones, or siloliths, are calcified deposits that form within the salivary ducts, most commonly the submandibular gland duct. They typically present with painful swelling of the affected gland, often triggered or worsened by eating when saliva production increases but flow is blocked. Sometimes it might just be swelling without much pain, or just pain without obvious swelling.
How are they treated?
Conservative therapy is often tried first, applying local heat, gently massaging the gland, staying well hydrated. Using things that stimulate saliva flow called secretagogues, like sugarless lemon drops or mints, can sometimes help flush out small stones. If secondary bacterial infection is suspected due to the blockage, antibiotics are given. Larger or persistent stones may require surgical removal.
Salidinitis refers to inflammation or infection of the salivary glands themselves.
Right. Acute bacterial parotitis infection of the parotid gland is the most common type. It's typically unilateral, seen more often in adults, especially those who are postoperative, dehydrated, or generally debilitated. The usual pathogen is Staphylococcus aureus, including MRSA strains now, as well as oral anaerobes.
Can it become chronic?
Chronic bacterial silodinitis can occur, often resulting from lowered salivary secretion or recurrent ductal obstruction, leading to repeated episodes of infection and inflammation.
If a suspected bacterial gland infection isn't responding to antibiotics, the differential diagnosis broadens.
Yes. If it's not clearing up as expected, the source advises considering other possibilities. Benign or malignant salivary gland neoplasms, tumors, lymphoproliferative disorders involving the glands, or systemic conditions that can cause gland enlargement or inflammation, such as Sjogren's syndrome, sarcoidosis, cat scratch disease, or even tuberculosis involving the glands.
And there are also non-inflammatory causes of salivary gland swelling mentioned?
Correct. Bilateral, usually painless salivary gland enlargement can be associated with systemic conditions like diabetes, mellitus, cirrhosis, bulimia, there's that link again, HIV/AIDS, and certain drugs, including iodide compounds and propylthiouracil, an antithyroid drug.
Finally, salivary gland neoplasms or tumors.
Salivary gland tumors can be benign or malignant. The source states the most common salivary gland neoplasm overall is the pleomorphic adenoma, also known as a benign mixed tumor. It accounts for about 2/3 of all salivary neoplasms and most commonly occurs in the parotid gland. It typically presents as a firm, slow-growing, painless mass. While benign, it has a tendency to recur if not completely excised with clear margins during surgery.
What about malignant tumors?
Malignant salivary gland tumors are less common but more serious. Examples given include mucoepidermoid carcinoma, adenoid cystic carcinoma, and adenocarcinoma. These tend to grow more rapidly than benign tumors, may become painful, can ulcerate through the overlying skin or mucosa, and have a propensity to invade nearby nerves, which can cause symptoms like facial numbness or even facial nerve paralysis if the parotid gland is involved.
How are these treated?
Treatment for most salivary gland tumors, both benign and malignant, is primarily surgical resection. For certain high-risk malignant types, or if surgery isn't feasible, radiation therapy, sometimes specialized types like neutron beam radiation, may be used either as primary treatment or after surgery.
And the prognosis for malignant tumors?
It varies significantly depending on the tumor type, grade, and stage at diagnosis. The source gives overall 5-year survival rates, around 94% if the cancer is still localized, but dropping dramatically to about 35% if it has spread to distant sites. Early detection is key.
That level of detail on salivary gland structure, function, disease, and management is definitely key for achieving that mastery we're aiming for. Now, a really crucial section for many clinicians, dental care considerations for medically complex patients. The source actually starts with a somewhat reassuring statement.
It does. It states that uncomplicated routine dental care procedures, things like simple extractions, periodontal scaling, cleaning, restorations, fillings, and even root canal therapy, are remarkably safe, even when performed in patients with significant underlying medical conditions.
That's good to hear. But there are specific risks that need careful management. Excessive bleeding, particularly in patients on anticoagulants, is a major one.
Yes, that's always a concern. The source specifically addresses warfarin, Coumadin. It emphasizes that clinically significant uncontrolled bleeding is actually rare if the patient's INR, the measure of warfarin's effect,
is maintained within the intended therapeutic range for their specific indication, like preventing venous thrombosis, managing atrial fibrillation, or for a mechanical heart valve.
But it warns against stopping the warfarin.
Critically, yes, it provides a strong warning. Serious embolic complications, including stroke and death, have been reported when anticoagulation was stopped or reduced to subtherapeutic levels, specifically for dental procedures. The recommendation based on this text is clear. Confirm the patient is therapeutically anticoagulated before the procedure and continue the warfarin through the procedure for most routine dental work. Local measures can usually control any minor bleeding.
What about antiplatelet medications like aspirin or clopidogrel?
For low-dose aspirin, typically 81 to 325 milligrams daily, used for cardiovascular prevention, the source says it can be safely continued without interruption for dental procedures. For patients on dual antiplatelet therapy, DAPT, like aspirin plus clopidogrel, often after coronary stent placement, the decision to continue the second agent needs to be individualized. It requires careful discussion between the dentist, the prescribing physician, and the patient, weighing the patient's specific risk of thrombosis if the drug is stopped versus the bleeding risk associated with the planned dental procedure.
And the newer direct oral anticoagulants, DOACs, like Davigato, apixaban, rivaroxaban.
For simple procedures, the text lists examples like 1-3 tooth extractions, minor periodontal surgery, incision and drainage of an abscess, or implant positioning. The source indicates these newer agents typically do not require interruption. However, for more expensive oral surgery, temporarily delaying or holding one or more doses, or potentially using more elaborate bridging measures may be necessary, requiring careful planning and consultation.
Okay, shifting to infection risk. Antibiotic prophylaxis before dental procedures is often discussed, especially for patients at risk of bacterial endocarditis.
Right. Patients considered at high risk for developing infective endocarditis, based on specific cardiac conditions, typically defined in guidelines like those referenced from Chapter 128, need special consideration. The first line of defense recommended is maintaining optimal oral hygiene, including regular flossing, and having regular professional dental cleanings to reduce the overall bacterial load in the mouth.
When are prophylactic antibiotics actually recommended according to current guidelines cited here?
The source states that current guidelines have significantly restricted the use of prophylactic antibiotics. They are now generally recommended only for these high-risk cardiac patients and only when they're undergoing specific dental procedures that involve significant manipulation of gingival tissue, the periapical region around the tooth root, or perforation of the oral mucosa. Not for routine fillings or simple cleaning in most cases.
What if unexpected bleeding occurs during a procedure in a high-risk patient not given prophylaxis beforehand?
The source offers reassurance here too. It notes that if significant unexpected bleeding occurs, administering the appropriate antibiotic regimen within 2 hours after the procedure is still considered effective prophylaxis.
What about patients with prosthetic joints, like hip or knee replacements? There's often confusion and concern about needing antibiotics before dental visits to prevent joint infection.
This is a common question. The source acknowledges that hematogenous seeding bacteria spreading through the bloodstream from an existing active oral infection, like a dental abscess or severe periodontitis, can, in rare cases, cause a late infection of a prosthetic joint. Treating that oral infection appropriately, with drainage, extraction, or root canal therapy, and using therapeutic antibiotics is necessary in that situation.
But what about prophylaxis for routine dental work?
Here, the source is quite definitive based on the evidence cited. It states that evidence demonstrating that late prosthetic joint infections commonly occur following routine dental procedures is lacking. Therefore, the current guideline recommendation is that antibiotic prophylaxis is generally not recommended for patients with prosthetic joint replacements prior to undergoing oral surgery or procedures involving mucosal manipulation.
So most people with joint replacements don't need antibiotics before dental work. Are there exceptions?
The text mentions that exceptions may be considered on an individual basis, usually in consultation with the patient's orthopedic surgeon, perhaps for patients who have a history of previous complications with their joint replacement, or those who are severely immunocompromised. But routine prophylaxis for all joint replacement patients is not advised here.
Okay, another area of concern is the use of vasoconstrictors, like epinephrine, commonly included in local anesthetic solutions, especially for patients with hypertension or heart disease.
Yes, there's often concern about the potential cardiovascular effects. However, the source points out the benefits of vasoconstrictors. They enhance the depth and duration of the local anesthesia, which means less total anesthetic drug might be needed, reducing potential systemic toxicity. They also help control localized bleeding during the procedure.
So, are they safe to use in cardiac patients?
The safety guidance provided in the text is quite specific. It states that provided careful aspiration is used to avoid accidental intravascular injection, standard dental formulations like 2% lidocaine with 1.100 1,000 epinephrine can be used safely in patients with controlled hypertension, stable coronary artery disease, stable arrhythmias, or even a history of MI or stroke that occurred more than 6 months previously.
Is there a dose limit?
Yes, the text advises limiting the total amount of epinephrine administered in these patients to the equivalent of about 2 cartridges of 1.100,000 epinephrine, which is approximately 0.036 milligram total.
So, generally safe with caution and dose limitation, not absolutely contraindicated in many stable cardiac patients.
Correct. The key is to use the minimal amount necessary to achieve adequate anesthesia and hemostasis. The source does add important cautions. Avoid using epinephrine-containing anesthetics or use them extremely sparingly in patients taking tricyclic antidepressants or non-selective beta blockers, as these drugs can significantly potentiate epinephrine's pressor effects.
Good point. What about the timing of elective dental care after major cardiovascular events like a heart attack or stroke?
The source provides recommendations here too. After a myocardial infarction, heart attack, it's advised to postpone elective dental care for at least 1 month, and preferably for 6 months, by which time the risk of reinfarction is generally low if the patient's condition is stable. After a stroke, the recommendation is to defer elective dental care for 6 months. Correction. The outline says 9 months. Let's stick to the outline's detail if possible. Checking outline says 9 months. Let's use that. After a stroke, defer elective care for 9 months.
And during necessary procedures for these patients?
The key focus should be on stress reduction. This includes ensuring excellent pain control during the procedure, which might paradoxically mean using appropriate local anesthetic with vasoconstrictor and keeping appointments relatively short if possible.
Finally, a specific issue, bisphosphonate therapy and the risk of osteonecrosis of the jaw, ONJ.
Yes, ONJ is a known, albeit uncommon, complication associated primarily with bisphosphonate drugs used to treat osteoporosis or certain cancers. The source clarifies the relative risks.
What's the risk with oral bisphosphonates commonly used for osteoporosis?
The risk of developing ONJ in patients taking standard oral bisphosphonates for osteoporosis is stated to be very low.
Where is the highest risk seen?
ONJ is most frequently observed in patients receiving high-dose intravenous IPAV, aminobisphosphonate therapy. Drugs like zoledronic acid or pamidronate, typically used to manage multiple myeloma or bone metastases from cancers like breast or prostate cancer. And crucially, the risk is highest in these patients who also undergo tooth extractions or other invasive dental surgery that involves the bone.
What does ONJ look like?
It typically presents as an area of exposed yellow-white hard bone in the mandible or maxilla that fails to heal after dental surgery or sometimes occurs spontaneously. It's often painful, according to the source, about 2/3 of cases.
Are there reliable screening tests to predict who will get ONJ?
The source states that screening tests for assessing ONJ risk have generally proven unreliable.
So what's the main recommendation for prevention, especially for those starting high-dose FAVI therapy?
Prevention is key. The strong recommendation is that patients who are scheduled to begin high-dose 5E aminobisphosphonate therapy should receive comprehensive preventive dental care before starting the drug treatment. This means addressing any existing infections, extracting non-restorable teeth, and completing any needed dental surgery before the bisphosphonate therapy begins to minimize the need for invasive procedures later on, when the risk of ONJ is higher.
That makes a lot of sense. Get the mouth healthy before starting the high-risk drug. That's a really thorough overview of managing dental care in medically complex patients, drawing very specific guidance from the text. Let's briefly cover halitosis, or bad breath, before moving to aging.
Okay, halitosis. The source states it typically originates either from the oral cavity itself or sometimes from the nasal passages.
What's the underlying cause?
It's usually caused by volatile sulfur compounds, VSCs. These smelly gases are produced by the bacterial decay or breakdown of food particles, cellular debris, and proteins trapped in the mouth.
So common oral causes relate back to things that trap bacteria and debris.
Exactly. Periodontal disease, especially with deep pockets, extensive dental caries, acute gingivitis like ANUG, poorly fitting or unclean dentures, oral abscesses, and significant coating on the back of the tongue are all listed as common oral causes.
How is it treated?
Treatment focuses on the underlying cause, correcting poor oral hygiene, treating any existing infections, periodontal disease, caries, ensuring dentures fit well and are cleaned properly, and adding tongue brushing or scraping to remove the coating from the posterior tongue where bacteria often accumulate.
Does dry mouth play a role?
Yes. The source notes that hyposalivation dry mouth can definitely contribute to or exacerbate halitosis because the reduced salivary flow impairs the natural cleansing mechanism of the mouth.
Are there non-oral causes to consider?
Yes. Pockets of decaying debris trapped in the tonsillar crypts, tonsil stones, can be a source. Problems with the esophagus that cause stasis, like an esophageal diverticulum or achalasia or a stricture, can lead to foul breath from retained food, chronic sinusitis or postnasal drip, and rarely a lung abscess.
And certain systemic diseases can produce characteristic breath odors?
They can. Severe kidney failure can cause an ammoniacal or urine-like odor, uremic fetor. Liver failure may produce a fishy or slightly sweet, musty odor, fetor hepaticus. Diabetic ketoacidosis classically causes a fruity or acetone-like smell. The source also adds an interesting point. Helicobacter pylori gastritis, the bacteria associated with stomach ulcers, can sometimes produce ammoniacal breath as well.
What if someone is convinced they have bad breath, but the clinician can't detect any odor?
The source mentions this possibility, pseudohalitosis or halitophobia. This is a psychological condition where the patient has a persistent worry about having bad breath despite lack of objective evidence. It requires sensitive handling and sometimes referral for psychological support.
Okay. Finally, before we transition to dyspnea, let's look at the section on aging and oral health. A key concept emphasized in the source is that tooth loss and dental disease are not normal, inevitable consequences of aging itself.
That's a really important message. While certain age-related physiological changes do occur in the oral cavity, significant dental disease and tooth loss in older adults are primarily the result of the cumulative effects of diseases like caries and periodontitis, lifestyle factors like diet and tobacco use, and barriers to care over a lifetime rather than aging per se.
What are some of those age-associated structural or functional changes mentioned?
In the tooth structure itself, the source describes a gradual diminishing of the pulp space and volume, sclerosis, hardening or narrowing, of the dental tubules, and alterations in the nerve and vascular content of the pulp.
What's the clinical result of those changes?
A key result is reduced pain sensitivity. Older teeth may not respond as strongly or as quickly to stimuli that would cause pain in a younger tooth. This also means there's potentially reduced reparative capacity within the tooth.
And that reduced pain sensitivity can be problematic, right? It's not necessarily a good thing.
It's definitely a double-edged sword. It means that significant disease like deep decay or chronic infection can progress quite far, becoming advanced and largely asymptomatic before the older patient even becomes aware of it. This can lead to more extensive destruction and potentially tooth loss that might have been preventable with earlier detection.
What about salivary glands and aging? Do they just naturally produce less saliva as we get older?
The source addresses this common belief. It says that age-associated fatty replacement of the acinar cells, the saliva-producing cells, may reduce the physiologic reserve capacity of the glands. This could make older individuals more susceptible to developing hyposalivation if other factors arise, like taking drying medications. However, it makes an important nuance explicit. In healthy, non-medicated older adults, studies generally show minimal or no significant reduction in overall salivary flow rates compared to younger adults. So significant dry mouth in an older person usually has a specific cause, most often medication.
Got it. So what factors do contribute most significantly to poor oral health outcomes often seen in the elderly population?
Several factors are highlighted. General health decline and the presence of multiple chronic illnesses often take precedence over oral health concerns. A significant factor is the loss of manual dexterity or upper extremity flexibility due to conditions like arthritis, stroke, or Parkinson's disease, which makes effective daily brushing and flossing much more difficult.
This is particularly relevant for frail older adults.
Yes, the source notes poor oral hygiene is common in frail older adults and residents of nursing homes, and it makes a powerful statement emphasizing the importance of addressing this. Regular oral cleaning and access to dental care in this vulnerable population have been shown to reduce the incidence of aspiration pneumonia, decrease oral disease burden, and may even reduce overall mortality risk.
That's a strong link between oral care and systemic health in that group.
Absolutely. Another factor mentioned is that many older adults had limited lifetime exposure to fluoride, especially community water fluoridation, compared to younger generations, leaving their teeth potentially more susceptible to decay.
And the consequence of declining self-care ability combined with reduced pain sensitivity.
It means decay can become advanced and asymptomatic.
As the text puts it, much or all of a tooth crown could be destroyed before the patient is even aware there's a problem.
What about periodontal disease and aging?
Periodontal disease remains a leading cause of tooth loss in older adults. Its prevalence is often measured by looking at the loss of alveolar bone height supporting the teeth. The source states that more than 90% of the U.S. population shows some degree of bone loss by age 50. However, it offers a somewhat reassuring note. Healthy adults who haven't experienced significant periodontal bone loss by age 60 typically do not experience significant worsening of their periodontal status simply due to advancing age, provided they maintain good hygiene and care.
Edentulous total tooth loss is becoming less common overall, but still impacts certain groups.
Yes. The source indicates that complete edentulous is becoming increasingly restricted to older individuals in lower socioeconomic groups in the U.S. Losing all teeth significantly impacts speech clarity, the ability to chew a variety of foods, which can affect nutrition, and facial aesthetics and contours. It can also exacerbate obstructive sleep apnea, especially in denture wearers who might not realize they have apnea.
And dentures themselves can cause problems if not managed well.
They can. Dentures, especially if they become loose or ill-fitting over time due to changes in the underlying jawbone, can cause pain from friction or lead to traumatic ulcers on the gums. Poor denture fit or inadequate hygiene can also predispose to denture stomatitis, which is often a form of candidiasis presenting as red, sometimes granular-looking tissue under the denture base. This may be asymptomatic or cause soreness.
Patients might expect dentures to be a perfect replacement.
Yes. The text notes that patients expecting dentures to fully restore their previous level of oral intake are often disappointed. Learning to function effectively with dentures requires significant adaptation and adjustment. And importantly, even individuals who are completely edentulous and wear dentures still need regular, at least annual, professional oral examinations to check the health of the underlying tissues and screen for any lesions, including oral cancer.
Wow. Chapter 36 was incredibly dense, but absolutely packed with critical details connecting the mouth to systemic health in so many ways. We've really journeyed from embryonic tooth development right through to the specific nuances of oral pain, managing medically complex patients, and the impact of aging. A true deep dive.
It really covers the landscape comprehensively.
Now, as the source itself transitions, we move into the very beginning of Chapter 37, introducing a fundamentally different yet equally vital clinical concept, dyspnea, shortness of breath.
Yes, this is a major shift in focus. We're moving from often visible, localized signs and structures in the oral cavity to a profoundly subjective, internal experience related to breathing. The source starts by providing a formal definition of dyspnea, citing the American Thoracic Society.
Right, and it defines it as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. That word subjective seems key.
It's the absolute core of the definition. Dyspnea is a symptom, something only the patient can feel and report. It's distinct from objective signs of respiratory distress that a clinician can observe or measure, like rapid breathing, tachypnea, use of accessory neck muscles, or intercostal retractions.
So it's the patient's perception.
Exactly. The definition goes on to say it arises from complex interactions among multiple factors, physiological, psychological, social, environmental, and that this experience may induce secondary physiological and behavioral responses, like anxiety or altered breathing patterns.
So it's not just about the simple mechanics of air moving in and out. It's how the brain and body perceive that whole process and the effort involved. How common is this subjective feeling of breathing discomfort?
The epidemiology statistics provided in the source are quite striking. It's reported by up to half of all hospitalized patients at some point during their stay. About a quarter of ambulatory patients seen in general medical clinics report it. In the general community, prevalence estimates range from 9% to 13% in adults, but rise significantly with age, reaching up to 37% in community-dwelling adults aged 70 or older.
And it drives people to seek urgent care.
Very much so.
Yeah.
It's a frequent cause of emergency department visits, accounting for an estimated 3 to 4 million visits annually in the U.S.
And the text mentions it has prognostic value. It tells us something about patient outcomes.
Increasingly so. The source notes that the degree of dyspnea, how severe the patient perceives it to be, is proving in some conditions to be a better predictor of outcomes than traditional objective lung function measures like FEV1. This is specifically mentioned for COPD, where dyspnea severity is now incorporated into formal severity assessments like the GOLD criteria. It may also predict outcomes in other chronic heart and lung diseases.
What about the underlying causes?
They are incredibly diverse.
The source states that most cases presenting to clinicians, perhaps up to 85%, will ultimately be attributable to pulmonary or cardiac conditions. However, it also notes that up to one-third of patients may have multifactorial reasons for their dyspnea, meaning more than one condition is contributing.
Can the way someone describes their breathlessness give clues to the cause, like air hunger versus chest tightness?
The source suggests that while specific descriptions or qualitative descriptors may sometimes hint at the underlying etiology or physiological mechanism, diagnostic testing is often needed for confirmation. The overlap is considerable.
Okay, let's get into the mechanisms proposed to underlie this subjective feeling. The text emphasizes complexity.
It does. It makes clear that dyspnea isn't a single uniform sensation. It likely encompasses several distinct contributory respiratory sensations, like the examples you gave: chest tightness, air hunger, increased effort, unsatisfied breath. And a given disease state probably produces the overall sensation of dyspnea via more than one mechanism operating simultaneously.
The source talks of afferent and efferent pathways. Let's break that down. Afferent signals are going to the brain.
Correct. Afferent pathways carry sensory information from the respiratory system and the chest wall up to the central nervous system. The text lists several key sources of these signals.
Right.
Peripheral chemoreceptors located in the carotid bodies in the neck and aortic bodies in the chest. These are activated by hypoxemia, low blood oxygen, hypercapnia, high blood carbon dioxide, and acidemia, increased blood acidity. Activation of these pathways is thought to contribute particularly to the sensation described as air hunger.
And central chemoreceptors.
Located in the medulla of the brainstem, these respond to the same triggers, particularly changes in CO2 and pH in the cerebrospinal fluid. They also likely contribute to air hunger.
What about receptors in the lungs and chest wall?
Mechanoreceptors. These sense physical forces and stretch. The source lists receptors in the upper airways, the lungs themselves, like stretch receptors, irritant receptors, and J receptors near the capillaries. And in the chest wall, muscle spindles in the respiratory muscles, tendon organs. These are activated by factors that increase the mechanical work of breathing, things like increased airway resistance, seen in asthma or COPD, or decreased compliance, increased stiffness of the lungs or chest wall, seen in pulmonary fibrosis or obesity. Activation of these pathways is often associated with the sensation described as chest tightness.
Are there other afferent signals involved?
Yes. The text also mentions potential contributions from pulmonary vascular receptors, which might sense changes in pressure or flow in the lung circulation, and skeletal muscle metaboreceptors, located in limb muscles, which sense biochemical changes related to exercise and might contribute to breathlessness during exertion.
Okay, so that's a complex array of incoming sensory information. What about the efferent signals, the outgoing messages from the brain?
Efferent signals are the motor commands sent from the respiratory centers in the CNS down to the respiratory muscles, diaphragm, intercostals, accessory muscles, telling them how forcefully and frequently to contract to drive ventilation.
How do these motor commands relate to the sensation of dyspnea?
The source explains that these outgoing efferent signals are also simultaneously transmitted via a pathway called corollary discharge to the sensory cortex of the brain. This internal copy of the motor command is believed to underlie the sensations we perceive as respiratory effort or the work of breathing. It might also contribute to the air hunger sensation, especially when there's an increased drive to breathe due to disease or exertion.
And the text highlights a key concept involving the interaction between these incoming and outgoing signals, the mismatch idea.
Yes, this is presented as a central mechanism in dyspnea perception, the concept of efferent-reafferent mismatch.
Okay, unpack that.
The idea is that the brain constantly compares the efferent motor command it sends out, telling the muscles to take a big breath, with the efferent sensory feedback it receives back from the lungs and chest wall about the actual mechanical result achieved. I actually get a big breath. This feedback loop involves integrative signaling.
So what happens when there's a mismatch?
If there's a discrepancy, for example, the brain sends a strong efferent command for increased ventilation, but due to lung disease or airway obstruction, the resulting efferent feedback indicates that the desired tidal volume or airflow wasn't achieved. This incongruence between the outgoing command and the incoming result is interpreted by the brain as unpleasant. It's perceived as dyspnea, particularly contributing to sensations like air hunger or unsatisfied inspiration.
So it's not just the signals themselves, but the brain's detection of a mismatch between the intended effort and the actual outcome that really drives that uncomfortable feeling.
Exactly. It's the brain essentially saying, I'm working really hard to breathe here, but I'm not getting the result I expect based on the feedback I'm receiving.
And adding another layer of complexity, the source reminds us that psychological factors like fear or anxiety can significantly heighten the perception of dyspnea. They might do this by directly increasing respiratory rate or causing disordered breathing patterns, or perhaps by lowering the threshold at which these physiological signals are perceived as distressing.
Given all this complexity and subjectivity, how is dyspnea actually assessed clinically, according to the text?
It acknowledges that assessment is challenging precisely because it's subjective and multidimensional. Dyspnea involves the sensory perceptual experience, what it feels like, the effect of distress it causes, how unpleasant it is, and its impact on daily function and quality of life. There's no single, uniformly agreed upon tool that perfectly captures all these domains, like a thermometer measures temperature.
But it should still be formally assessed.
Yes. The consensus view presented is that dyspnea should be formally assessed in clinical practice, using tools or methods relevant to the specific patient management context. For example, tracking response to therapy, assessing severity. And clinicians should be clear about which specific domain or aspect of dyspnea is being measured by the tool they choose. Emerging tools are noted to be under development.
Is an example tool mentioned?
Yes, the text references Table 37 of the 1, which contains the Modified Medical Research Council, MMRC, dyspnea scale as an example. It highlights that this scale is advocated by the GOLD criteria for assessing symptom burden and impact in COPD patients. Scales like the MMRC typically work by grading the patient's level of breathlessness based on the degree of physical activity required to provoke it. For example, breathless only with strenuous exercise versus too breathless to leave the house.
Okay. Finally, this introductory section of Chapter 37 gives a brief overview of the differential diagnosis, particularly for chronic dyspnea, defined as lasting longer than 1 month.
Right. It reiterates the point that pulmonary or cardiac conditions are the most common culprits, accounting for up to 85% of cases. But it also stresses that up to 1/3 of patients may have multifactorial causes contributing simultaneously.
Does it give specific examples?
It refers to Table 37-2, which we don't have in front of us, but it describes the categories. It mentions broad categories within the respiratory system, including diseases affecting the airways like asthma, COPD, chronic bronchitis, and diseases affecting the lung parenchyma, the substance of the lung. Parenchymal causes are further divided into interstitial lung diseases like pulmonary fibrosis or sarcoidosis, and conditions involving alveolar filling like hypersensitivity pneumonitis or BOP-TOP. It just gives a sense of the broad spectrum of conditions that need to be considered when a patient presents with chronic dyspnea.
So, even this initial introduction to dyspnea makes it clear just how complex it is, a deeply subjective symptom driven by multiple interacting physiological and psychological mechanisms, requiring careful, formalized assessment and a very broad differential diagnosis.
It absolutely underscores that understanding dyspnea requires looking far beyond just noting short of breath on a chart. It's about truly appreciating the patient's unique experience and then systematically exploring the wide range of potential underlying causes and contributing factors.
Well, we have certainly covered a significant amount of ground in this deep dive today. We've moved from the very tangible structures, the diseases, the systemic reflections within the oral cavity as detailed in Chapter 36, right through to this introduction to the highly subjective yet clinically critical experience of dyspnea at the start of Chapter 37. We've really tried to delve into the specifics highlighted in your source text, aiming for that mastery level by understanding the why behind the key details, the connections, and the clinical implications.
It's been fascinating to see laid out so clearly how conditions like diabetes, HIV, autoimmune disorders can manifest right there in the mouth. And conversely, how oral issues like infections can potentially spread systemically, or how dental care itself needs very specific management considerations in medically complex patients. It truly emphasizes the interconnectedness of the entire body.
It really does.
And then, transitioning to dyspnea, it's such a powerful reminder that symptoms aren't always neat, objective measurements. They are deeply felt experiences, arising from this incredibly complex interplay of signals and perception, requiring careful listening and interpretation from us as clinicians.
For you, the listener, we sincerely hope this detailed exploration of the text's content provides a really solid foundation, revealing the depth and the significance hidden within these seemingly disparate topics of oral health and breathing discomfort.
Considering the emphasis the text placed on the subjective nature of both pain, which we discussed extensively in the context of the mouth and dyspnea, and also thinking about how some conditions, like that drug-induced gingival hyperplasia, can potentially be prevented or minimized with diligent patient action.
It makes you wonder, what responsibility do we have, maybe as individuals or as healthcare providers, to really pay close attention to those subtle signals our body gives us, or that our patients try to communicate, especially those subjective ones that might lack clear objective signs early on.
That's a really powerful thought. It ties back beautifully to that dry mouth point, too. The subjective feeling often precedes the objectively measurable 50% reduction in flow. And thinking about all those myriad ways systemic conditions showed up unexpectedly in the mouth, it prompts the question, what other seemingly isolated body parts might be holding hidden clues to our overall health? Clues that perhaps we just haven't yet learned to recognize or fully appreciate.
Excellent points for reflection. This deep dive has certainly given us, and hopefully you, a lot to consider about looking closer and listening better.
Indeed. We hope this has been a valuable and insightful journey into these important topics, drawing directly from your source material.